is part 2 of a series of 4 videos on the cardiovascular system, blood vessels, and circulation. We're going to begin this series by looking at blood flow, pressure, and resistance. Blood flow is basically the movement of blood through a vessel, tissue, or organ, and is measured in volume over time. Remember that blood will flow down its pressure gradient from high pressure to low pressure, and resistance is what can slow down or impede the flow of blood. The greater the resistance, the slower the flow. Blood pressure, which is a hydrostatic force, is the pressure of blood against the walls of a vessel, and we usually measure blood pressure in systemic arteries. It's measured as millimeters of mercury, and it's usually obtained by way of the brachial artery. We actually have a slide where we're going to go through how to do a correct blood pressure measurement. So as we look at arterial blood pressure, we get two measurements when somebody takes and records blood pressure. There's a systolic pressure that occurs when the ventricles contract, and there's a diastolic pressure that is lower because that is the pressure of blood against the blood vessel walls when the ventricles are relaxed. Now, the difference between systolic and diastolic measurements is what we call pulse pressure, and that should be about 25% of the systolic measurement. Remember that everybody's body is different and bodies don't read books, so it's always a good idea to ask someone if he or she knows what his or her blood pressure normally is. That can give you some really good information. Mean arterial pressure is defined as the pressure on average of arterial blood, and there's a way to figure that out. In order to calculate mean arterial pressure, which again is the average pressure of blood in arteries, we have to take the diastolic blood pressure plus the pulse pressure and divide the pulse pressure by 3 before we add that to the diastolic blood pressure. So if we were to calculate pulse pressure and mean arterial pressure for somebody who has a blood pressure reading of 120/80 millimeters of mercury, the pulse pressure, subtracting 80 from 120, is 40. And remember that we're going to start with the diastolic blood pressure, which is 80. And then we have to take 40 divided by 3 to get 13.3. So our mean arterial pressure is going to end up being 93.3 millimeters of mercury. Let's try this again. Say we calculate a pulse pressure and mean arterial pressure for somebody who's got a blood pressure of 140/100. So here we still have a pulse pressure of 40. We know that 40 divided by 3 is 13.3. So we take the diastolic reading, the 100, add that to the 13.3, and now we get 113.3 millimeters of mercury as our mean arterial pressure. Now, if somebody's got a real big or gap in the pulse pressure, or if it's really slight, that can be indicative of heart problems. So keep that in mind. If someone is to measure a pulse, usually the radial artery is what's used to feel for the expansion and recoil of that artery due to the elastic fibers within it. And even though the feeling of a pulse can diminish as we get farther away from the heart, the rate remains the same. So this is how we measure heart rate. The strength of a pulse is indicative of ventricular contraction and cardiac output, and other things can affect arterial pulse rates like emotions, activity, postural changes. Those can all affect heart rate, therefore they can affect the rate of the pulse. Now, if you've ever heard of white coat syndrome, that's what happens if a person goes to the doctor's office and for a routine checkup has this pulse and blood pressure done, and the values are a little bit higher than normal. Usually if the person has rushed to get there on time, or is feeling nervous because there's a person of authority measuring pulse and blood pressure, it can actually be a little bit elevated, and that's what white coat syndrome is. In order to properly measure blood pressure, the clinician should make sure that the patient, if sitting, has his or her legs uncrossed and that the arm to be measured is at heart level. The left arm is always preferable to use when measuring blood pressure. The clinician should place the cuff on the arm approximately 1.5 to 2 inches above the cubital crease, and the clinician should then palpate for the brachial artery on that same side. The cuff should be snugly on the arm. If it doesn't fit snugly on the arm, that can change the reading of the blood pressure. Considering everything is set up properly, the clinician, while palpating the brachial artery, will pump up the cuff while watching the pressure reading on the sphygmomanometer. As soon as the clinician feels the brachial artery pulse disappear, the clinician should note the reading on the sphygmomanometer, making a note of it. The clinician should then deflate the cuff and wait 15 seconds. Then the clinician will use the bell of the stethoscope over the brachial artery, pumping up the cuff 30 millimeters of mercury above the initial reading in order to avoid an auscultatory gap, which is a gap that can be common in people who have hypertension. After reaching that number, slowly deflate the cuff approximately 2 to 3 millimeters of mercury per second, watching the sphygmomanometer for a blip while hearing for the first sound. The first sound that's heard is the first cough sound, which indicates systolic pressure. While continuing to deflate the cuff, the clinician will notice that that needle continues to blip until it reaches the diastolic pressure, at which point it will stop. Make a visual note and listen for the turbulence in the artery, known as bruit, to disappear. When that disappears, that is the diastolic pressure reading. Now I've got a video on this slide, but those are really the directions that you need to properly take a blood pressure measurement. Different variables that can affect blood pressure readings include things like cardiac output, compliance of blood vessels, the volume of blood, the viscosity or thickness of blood, as well as the length and diameter of blood vessels. You may recall from the endocrine system that the right atrium produces atrial natriuretic peptide, which is a hormone that helps regulate blood pressure as well as salt and water balance. The atrium will secrete atrial natriuretic peptide hormone when there is increased atrial pressure. And that helps lower blood pressure by causing excretion of water and sodium by the kidneys, as well as by stimulating vasodilation. Oddly enough, people who snore tend to stretch the atria, so that may actually make them produce more urine while they're sleeping at night. Remember that cardiac output is the amount of blood pumped out by each ventricle per minute, and it's usually measured in liters per minute. Cardiac output, as you remember, varies with heart rate and stroke volume directly, because if we increase the speed, the heart rate at which the heart is beating, or if we increase the stroke volume, which is the amount of blood ejected by that ventricle, then we can increase cardiac output. So either one of those factors or both will increase cardiac output. When we talk about blood vessel compliance, remember, compliance is the ability to expand and accommodate an increase in the volume of blood. And veins are actually more compliant than arteries. And if we have a decrease in compliance, then that's going to decrease the blood flow, because if the blood vessel's not stretching to accommodate that volume, well, that means less blood can go through that vessel. In this slide, we're going to discuss Poiseuille's equation, and there are three variables to this equation: viscosity, which is the thickness of the blood, the length of the blood vessel, and the radius of the lumen of the blood vessel. So two important things to know about the equation is that in terms of viscosity or thickness of blood, the more thick the blood is, the greater the resistance of the flow of the blood through a blood vessel. The longer the length of the vessel, the greater the resistance to blood flow. And then those two things, viscosity and the length of the vessel, change slowly in the body. However, because the diameter of a blood vessel can change, that's going to affect the radius. Remember that the radius is simply half of the diameter of a circle. So when we look at the lumen of a blood vessel, the blood vessel can change very rapidly. It can either undergo vasoconstriction or vasodilation, and small changes in the radius greatly affect flow, because that's the one variable that is raised to the fourth power in this equation. I'll say that again. The radius is the value that is raised to the fourth power in this equation, which is why the radius greatly affects resistance to blood flow. The more vasodilation, right, the greater the radius, the less resistance there is, because it's an inverse proportion. The smaller the lumen, the less the radius is, and again, because it's inversely related, that means there's going to be a greater resistance. So in looking at the variables that affect the volume of blood, and that would affect blood pressure, if there is a condition of low blood volume, we call that hypervolemia, and a person who is hypervolemic may have gotten there because of excessive bleeding, dehydration, vomiting, diarrhea, severe burns, even hypertension medications can cause the kidneys to excrete fluid, and sometimes too much. So if there's 10 to 20% of blood loss, that will cause hypovolemia. Conversely, hypervolemia is where we have excessive fluid volume in the bloodstream, and that can be due to either retention of water or sodium. It can be due to heart failure or liver disease or kidney disease. If the kidneys aren't kicking out enough fluid as blood gets filtered from them or through them. And hyperaldosteronism. Remember, aldosterone is involved in the renin-angiotensin-aldosterone system, where aldosterone helps absorb sodium and water follows to increase blood pressure. So if we've got too much aldosterone, that could cause hypervolemia, and some steroid treatments as well can cause fluid retention, leading to hypervolemia. So let's look at viscosity. There's Poiseuille's equation again, where 8 nu lambda divided by pi r to the fourth power, r being the radius of the blood vessel. Remember that viscosity is directly proportional to resistance and indirectly proportional to flow. What does that mean? So the greater the thickness or viscosity, the more resistance and the harder it is going to be for that flow to occur. That's going to mean that we need more pressure to get it through. So that's going to actually cause an increase in blood pressure. Blood vessel length is directly proportional to resistance due to increased surface area. The longer the blood has to travel, the more of the interior vessel wall the blood comes in contact with, which is a resistive factor. So the longer the vessel, the more resistance. And a person who is roughly 150 pounds can have up to 60,000 miles of blood vessels. But if a person gains weight, for every 10 pounds added, that can add an extra 2,000 to 4,000 miles of blood vessels. Now, this is a slow change that occurs over time. This slide is discussing the fact that diameter is inversely proportional to the resistance. And that means the greater the diameter, the less the resistance. Now you're going to have to excuse the picture over there, because that's actually showing you what happens with changes in diameter with the speed or velocity of flow. And I was looking for a picture that was more appropriate to this slide and actually couldn't find anything when I searched online. So, basically what it shows is that if the diameter is small, that increases the rate of flow. If there's no change in other variables, it's similar to if you have a hose and it only reaches so far and you want to get the water to have more speed to shoot farther, you stick your thumb on the end of the opening to make it smaller, and so that increases the velocity. So if you decrease the diameter, you increase the speed or velocity, increase the diameter, decrease the speed or velocity. But we're not talking about speed and velocity with Poiseuille's equation. We're talking about diameter and resistance. So if the diameter of a blood vessel increases, the resistance decreases. If the diameter decreases, the resistance increases. That's what we call something that's inversely proportional. And remember that the radius is what is involved in this equation, and it's the radius to the 4th power. So small changes in the diameter can have dramatic results. These charts take a look at several factors that affect blood flow and pressure and the speed of blood flow. The charts are looking at something called the blood vessel cross-sectional area. So this is the area of a cross-section of blood vessels of a certain type. So if we look at the chart that way, on the left-hand side, you'll see that cross-sectional area is the green line. It's the one that comes to a peak right at about 45 to 60,000 centimeters square, and that the velocity or speed of blood is the black line. And it starts a little bit higher on the left side of that chart on the left. So the reason that the total cross-sectional area of blood vessels is greater when we start going from arterioles to capillaries and then back through venules and veins, it gets smaller again, is because we've got a lot of those little vessels. And so that's why the total cross-sectional area of those kinds of vessels is going to increase as we get small, and then as we go down to back through venules, veins, and the big vena cava, it gets smaller again in terms of total cross-sectional area. So this chart shows, if we look on the left-hand side at the black line, that the velocity of blood flow is inversely related to blood volume cross-sectional area. In other words, there's not as much area for the blood to travel, so it can go faster. Then when we get to the capillaries and switch over to, and actually at the height of capillaries, between the capillaries and the venules, that's when the cross-sectional area is the greatest. So we've got a lot of these little vessels that blood has to go through. So that means the velocity is going to slow down. It's starting to go through these tiny little vessels, and there's a lot of them. And then we see that, again, the two lower boxes on the left basically say what I said, that the velocity decreases from the aorta to the arteries to the capillaries, but then it does speed up as we go through the venules, veins, and vena cava to get back to the heart. It does speed up a little bit because now we don't have as much of that cross-sectional area and we don't have as much resistance, so that blood velocity can increase. So from the veins to the right atrium, it goes faster. So if we look at the chart on the right-hand side, you'll see that they broke down vessel diameter at the top left of the chart on the right. So the top left is vessel diameter, how it is big in those bigger elastic arteries like the aorta, and then we go to the muscular arteries. The vessel diameter is really small when we get to the arterioles, the capillaries, the venules, and then the diameter gets bigger as we go up towards the vena cava. The total cross-sectional area is on the top right of the 4 pictures on the right, and you can see how that cross-sectional area increases because there's a ton of capillaries, so there's a lot of area that the blood has to travel through. And then if we look at the average blood pressure on the chart right here on the lower left side, we can see that the blood pressure is highest at those elastic arteries when it first comes out of the heart, and then it's going to drop down right as it comes back to the heart. And interestingly enough, again, we said that the velocity of blood flow initially is very high, slows down as it gets through the small blood vessels, and then starts to increase as it gets back to the vena cava, because we've got structures that help move the blood back to the heart that are external to the veins. Specifically, muscles are going to help squeeze the blood and help it flow a little bit faster to the heart. So as far as the pressure relationships in the venous system go, I already said that because the diameter is going to increase when we go from capillaries to venules to veins in the vena cava, from smaller to larger, but the total cross-sectional area decreases. From venules to veins, pressure decreases, but velocity increases. So any action increasing venous flow will also increase venous return. So blood flow, pressure, and resistance can change when there is a disease known as arteriosclerosis. Remember, sclerosis is the conditioning of hardening and or narrowing. And what that means is that if there is injury to the inner lining of the blood vessel, the endothelium, or if there's a lot of sugar in the blood that's going to stick to the walls of the blood vessel, or infection, or even nicotine, or too much fat in a person's diet, that can reduce the compliance of the blood vessel. So the blood vessel, instead of being able to stretch and recoil, is not able to do that as effectively. And sometimes when plaques form in arteries, that plaque is what we call a thrombus. If it breaks off, it can become an embolus. That's singular for emboli. And if emboli travel through blood vessels, they can cause things like a heart attack or stroke. They can also lead to ischemia, which is a lack of blood flow to a certain organ or tissue. And with ischemia comes low blood oxygen or hypoxia. If you're not getting blood to an area, there's no oxygen getting to that area. So what can be done with arteriosclerosis? Well, obviously, if a blood vessel is becoming occluded, there are ways to help open it up. And one of those ways is by using a procedure known as balloon angioplasty, where a catheter is inserted with a portion that can inflate and compress the plaque on against the arterial walls, helping to open that space up, and then that catheter is removed and the wall of that portion of the artery has been widened. Another type of stent that can be inserted in a procedure known as stent angioplasty is when a catheter is inserted and there's not just a balloon but a little mesh-like stent that gets inserted in that area to help protect that area of the blood vessel from collapsing down or closing in. And so that would be stent angioplasty. So other things that can be done to manage arteriosclerosis besides these types of angioplasties include things like lifestyle changes, exercise, watching one's diet, making sure a person is eating real food and not super processed foods. Endarterectomies can be done where they go in and actually remove the plaque surgically, scrape it out. And then coronary bypasses can be done where they actually remove a blood vessel if it's within the heart. That's a coronary bypass where they remove a portion of a blood vessel and replace it with another blood vessel from that individual. Usually it's replaced by part of a vein. So unlike arterial constriction, when we have venous constriction, that's going to increase blood flow, and again that's going to happen because of smooth muscles around veins, and that venoconstriction, as more blood goes back to the heart, is going to increase preload or stretch if we have more than normal blood volumes going back to the right atrium. So remember that venous blood has got to come back to the right atrium of the heart, and there are two factors that help to push that venous blood back against gravity towards the heart and help move it into the heart. Remember that during diastole, which is relaxation, atrial diastole means that the atria is relaxed and that the pressure within those chambers is low. And so as venous blood comes back to the heart, well, we have skeletal muscle that helps, when it contracts, pump and move that venous blood through the valves towards the heart. But there's also a respiratory factor. When a person inhales, that increases the volume of the thoracic cavity, and that causes a decrease in intrathoracic pressure, while the abdominopelvic cavity has an increase in intra-abdominal pressure because of that diaphragm moving down. That increases intra-abdominal pressure. So we go from high pressure in the abdomen to lower pressure in the thorax, and that helps push blood, venous blood, back up towards the right atrium. And then when we exhale, that increased blood flow goes back into the heart, because now we have increased intrathoracic pressure when we exhale. That helps move blood through the superior and inferior cava to the right atrium, while the diaphragm relaxes and we have decreased intra-abdominal pressure, which allows more blood to come up into the abdomen. We can see venous blood coming back up into the abdomen as we release the diaphragm and have that decreased intra-abdominal pressure. So that's how we get blood not only back up to the heart, but actually in the heart, because we're creating pressure when we exhale. That actually helps the blood flow from high pressure in the vena cava to low pressure in the right atrium. Hydrostatic pressure is important because when we look at bulk flow, that's the mass movement of fluids through capillary beds and tissues. Remember that the tissues surrounding capillaries consist of cells which are surrounded by small amounts of fluid known as extracellular fluid or interstitial fluid. Now, if we look at this particular picture on my left, you'll notice that at the far end on the left side of the picture, we see that at the arterial end of a capillary, that fluid will exit or leak through the capillary because hydrostatic pressure, which is pressure formed by fluid against the wall of a vessel, is going to be greater than the colloid osmotic pressure in the blood. Colloid osmotic pressure, remember osmosis, water follows solutes. So the blood, because there are proteins in blood and other solutes in the plasma, right? We've got albumin and globulin in blood plasma as well as other ions. So those are going to form the osmotic factors that are kind of saying, wait, fluid, we love you, come back to us, right? Water follows solute. So they're the solutes going, hey, come back, we want you. So the hydrostatic force is what's going to push some of the plasma out of the capillary into the interstitial fluid. And because that force is 35 millimeters of mercury at the arterial end of a capillary, and it's greater than blood colloid osmotic pressure, which is 25 millimeters of mercury, we see a net filtration occur where we have 10 millimeters of mercury of pressure moving some of the plasma into the interstitium, becoming interstitial fluid. As we move to the middle of the capillary, we see that there's no net movement occurring. It goes in and out, but there's no net movement occurring because capillary hydrostatic pressure, which is equal to the blood pressure at that point, is equal to blood colloid osmotic pressure. So the pressures are equal. Fluid can go in and out, but there's no net gain or loss. And then when we get back to the other end of the capillary, to the venous end on the far right of this picture, now we have fluid coming back into the capillary because at this point, because the blood has traveled a longer distance, experiencing resistance, and the pressure drops to about 18 millimeters of mercury now, we have less capillary hydrostatic pressure than we have blood colloid osmotic pressure because we still have the proteins in the plasma, and so we still have that 25 millimeters of mercury in the venous end for blood colloid osmotic pressure. So that's where we reabsorb some of that interstitial fluid. When the fluid leaves the capillary, it becomes interstitial fluid, and then interstitial fluid can be resorbed on the venous end of that capillary because the colloid osmotic pressure is higher than the capillary hydrostatic pressure at that point. So again, osmotic pressure is going to draw fluid back in towards it, and that's determined by gradients, pressure gradients for filtration, osmotic gradients for reabsorption. And so when we look at this, again, we see that plasma proteins, like albumin and globulin, not formed elements, red blood cells, white blood cells, platelets, not those, but it's the plasma proteins that are going to determine the osmotic gradient. And they do form a colloid rather than a solution. So there is also interstitial fluid colloid osmotic pressure and interstitial fluid hydrostatic pressure, but that tends to balance out and it doesn't really contribute one way or the other to the net movement of fluid. And so if we look at this picture closely where it says filtration, we see that we filter roughly 24 liters a day, but we reabsorb 20.4 liters a day. And so where does that excess interstitial fluid go? Because if it doesn't go anywhere, we're just going to have edema building up. Well, it actually gets picked up by a lymphatic capillary. I don't know if you can see on this picture, but a lymphatic capillary is a closed-end tubule. And so the force of the increase in fluid in the interstitium, that interstitial fluid is actually going to be soaked up by these little lymphatic capillaries, which in turn go through lymphatic vessels and lymph nodes, and then they finally get to go back into the bloodstream. That's where lymphatic fluid dumps back into it, actually goes back into the bloodstream. So it's a closed circuit if you think about it. Here we have another picture of the lymphatic capillaries, which go to or through lymphatic ducts. Once the interstitial fluid goes into the lymphatic capillary, it's referred to as lymphatic fluid. And because capillary hydrostatic pressure is higher than blood colloid osmotic pressure, we're going to have more fluid going into the interstitial fluid from capillaries than is being resorbed, and that's why the lymphatic capillaries are so important to pick up that excess fluid and send it through the lymphatic system. It will travel through lymphatic nodes and lymphatic vessels, and it will go back into the bloodstream. It will actually dump back into our veins, and I'll show you where that occurs in a later video. So we go from blood plasma to interstitial fluid to lymphatic fluid back to blood plasma, because that recycled blood plasma just keeps going through the circulation. And that's the last slide for this video.